Morning, everyone. Guess we can get started. So welcome to Medicine Grand Rounds. My name is David Sturkin, and I'm one of the hospitals here at UW. It's my pleasure this morning to introduce Dr. Andy Auerbach, a professor in medicine at the University of California, San Francisco. Dr. Auerbach attended medical school at Dartmouth, moved to Yale for residency, and then completed an MPH and general medicine fellowship at Harvard. He's been a very active member in the academic hospital medicine community, both in research, mentorship, and in leadership. He's received numerous awards for his service, and just to name a few, he's received the UCSF Pepper Center Genius Award. He's been named a Master in Hospital Medicine by the Society of Hospital Medicine, and he served as the editor-in-chief of the Journal of Hospital Medicine from 2011 to 2018. Regarding today's Grand Rounds, Dr. Auerbach is one of the co-founders of the Hospital Medicine Reengineering Network, also called Home Run, which is a collaborative of more than 50 different hospital medicine networks nationwide. Home Run has conducted a number of different multi-center studies, including the subject of today's talk, the UPSIDE study, which investigated diagnostic errors in hospitalized patients, looking for potential predictors of such errors. And with that, I'll leave it to Dr. Auerbach to explain the rest.
Good morning. Can you guys hear me okay? Great. Thank you, David. That was really, really awesome of you. I'll get started here. So I guess I have to show this slide, all the accreditation issues. So I have no financial relationships with ineligible companies to disclose. I do get royalties from Up to Date, where I edit the hospital medicine sections. I have the research funding there, and we've funded a nonprofit health, digital health collaborative called Advice Health, which doesn't give me any revenue, much to my chagrin. So this is a play in 3 acts. The first act is talking about Home Run, which David just alluded to a minute ago, where it came from in this new field of hospital medicine. We'll go into the UPSIDE study and what we're doing to study diagnostic errors. And I'll end with some thinking about where we're going to go next, both as a field as well as Home Run and the UPSIDE study. So every good Grand Rounds has to start, or most good grants, hopefully this is a good one, we'll start with an origin story. And this is a sushi restaurant in Northampton, Massachusetts, near where my friend Peter Lindenauer and I had lunch one day, maybe 12 years ago. And we were having coffee, having sushi, and saying, where is the hospital medicine research network? The cardiologists have them, the emergency physicians have them, critical care has them. Like, where is the hospital medicine research network? It also was happening around the time we were doing all these things, 100,000 Lives campaign, a bunch of things happening in quality improvement. And we were doing all these kind of good ideas, but maybe a little outlandish in terms of lack of evidence. And we thought, well, it'd be reasonable to study these things instead of just do stuff. We also noticed this curve, when we founded Home Run, it was maybe 2010. We were on that upward growth curve. And we were saying the hospitalists were just, when I started at UCSF, there were 6, now there are 106. The same kind of growth has happened here nationally, same thing, and kind of wondering whether that was an opportunity. Before, to take care of patients with pneumonia, you had to find 7 PCPs and a pulmonary doctor. Now it's the hospitalist. So much easier to think about doing studies in that model. We have a huge influence over the annual spend in healthcare, so that made it more important to kind of engage hospitalists in research. There's a list of things we're doing here, and particularly in the COVID-19 pandemic. I think you're involved with this project as well. We're talking to CEOs. It turns out CEOs realize that we've been pretty invaluable to getting through the pandemic, along with emergency physicians and critical care. Like, it's been very difficult for them to imagine getting through the pandemic without hospitalists. And as a specialty, we are very focused on healthcare delivery, quality, safety, systems redesign. That was kind of where we came from. We fit a need. And as a culture, a specialty, we've kind of focused on that as kind of core of what we do and what we study. Sadly, we don't have a strong academic base. We've grown really, really quickly. Places like University of Wisconsin have done a great job building their academic base, but the number of hospitalists who actually do research or who are funded to do research is actually extraordinarily small. If you've picked 40,000 cardiologists in the country right now, you'd probably find several hundred people with kind of focus with high-level grant funding. In the field of hospital medicine, there's maybe a dozen at the most. This is a study that Evan Shannon had in JHM 2 years ago now, We surveyed 43 leading academic hospital medicine programs, places like this, places like UCSF, the Brigham, and at that place, 22 of them had no clinician investigators at all. Again, if you looked at the cardiology departments of those same institutions, we would probably see a very different result. So this is kind of the burning platform of where Home Run came from. So again, back when we started, we called our friends. I didn't know Ann particularly well then, so I didn't pick up the phone to call you, but we would have. And we just said, are you willing to work for free? That's basically what it was. We were on this vision. We wanted to lift up the field, do research together, knowing there weren't many researchers out there. There was actually little, if any, funding for the kind of work we wanted to do, and started to do some collaborative work together. So we were fortunate enough to talk to some people at AAMC who shared our vision. And we said, what can we do together? At that point, we were all about DVT prophylaxis. Remember this era, DVT prophylaxis. And they said, no, you should talk to the deans, your CEOs, your CMOs, and say what they're really important, what they think is really important. So we did that, and we focused on something very different. But it was very key for us was that was a way to really become a health system embedded research network. We were doing stuff that was important to both the health system and the patients and us. That led, instead of DVT prophylaxis, to us doing a study of readmissions, which at the time was the top 15 of 10 things we were doing in healthcare. So we said, we're doing lots of things for readmissions. We'd like to know where to target those interventions. We'd like to know, like, we can't do all the things. We have to focus on the people who need it most and do the things that are most likely to help. So we called those 13 sites, and we focused on figuring out the proportion of readmissions at those hospitals that were preventable, what factors were contributing to readmissions, and then start to model out a little bit what we could do to reduce the readmission risk. We randomly selected patients at each of these sites, about 100 each site, about 1,000 total, to do chart reviews. We actually interviewed the patients. We had talked to the doctor who discharged them, the doctors who admitted them, and their primary care doctor. I won't go into those data during this study, but that was a particularly interesting part of our work. We did a chart review, and then had 2 doctors look at every chart to decide whether readmission was preventable or not. Got all those data together, the surveys, the interviews, chart data, and we sat in a room and we said, could we have prevented this readmission? This slide here shows the results. I'll try to, let's see, we get a laser here. The preventability scale is those the lower 3 rows there. It's about 27% of readmissions were preventable in our data. And if you look at the lower half of the tables, most of the effort would have been in the index admission or soon thereafterwards. So we thought, well, this is definitely a hospital medicine own problem. It turns out the people who had preventable readmissions were almost identical to the people who did not have preventable readmissions. So if you looked at their age, their comorbidities, the kind of the stuff you would think about as kind of clinical risk factors, we didn't do as much detailed social determinants of health in this study as we would have if we did that study now. But certainly that was the patients based on if you're going to build a risk prediction rule off of like comorbidities and functional status, we would not be able to determine the 2 groups just on that alone. So this table shows the underlying risk factors here. The adjusted odds of preventability are here. Let's see if I got the laser here. So these are all the risk factors. These are all statistically associated with readmission. And then if you look at this column here, this is this here is what they call the attributable fraction. It's if you are able to eliminate the example of inappropriate discharge location, if you eliminated that factor entirely from your health system, you'd reduce the proportion of or percent of preventable readmissions by 5%. That makes sense? So if you look at the top 4 things that we found, the emergency department decided to admit the patient that probably shouldn't have. I'll come back to that in a minute, knowing there's at least one emergency medicine physician in the room. Patient was not able to keep post-discharge appointments. Discharged too soon, didn't make me many friends in the CMO office. And then lack of awareness who to contact. The ED one was more about as we dug into those cases, less about the ED making bad clinical choices, because they weren't. It was because they had no place else to send the patient at 1 a.m. on a Saturday. There was no clinic to follow up with, that sort of thing. So we viewed that as more of the ED as a canary in the coal mine of a broken primary care system. But some of these other things were clearly things we could think about. Discharge too soon, patient, I was talking about this last night over dinner, like sometimes you have to send people home kind of hopefully, but you can't keep them there forever. But that was always a judgment call for us figuring out where that would be. We thought that was certainly a place that we could focus on. The rest of these are appointments and who to contact are things we have focused on very heavily as a field. Make sense? So as opposed to the boil the ocean approach, as my boss said at the time, like we're going to do Boost, we're going to do Project Red, we're going to do coaching and navigation. Everyone's going to get all the things. We started to really cone down on some really key areas. I can't say we've solved the gaps in primary care yet. It's just still really hard sometimes, but we're working more on readiness for discharge things. And if you can do more appropriate post-discharge supports, you can sometimes discharge people earlier, safer. Kelly Graham at the BI in Boston took these same data. I put this up because I know Anne's been interested in this area, because at the time we were being held to a 30-day readmission penalty. And her question was like, when does preventability kind of start to fall off? Like, is the early readmissions or is the late readmissions? Are those more important? And she's noticed that it's really the first 7 days where the preventability was really in that first 7 days. And then if you look at this curve, there's this beautiful curve that it just kind of it goes down this neat kind of flat level of preventability at day 7, which starts to feel more like this is stuff that we did to the patient, and this may just be a baseline hospitalization rate for these pretty sick patients. I don't know if this got into policy. It certainly was helpful for us to think at UCSF about how we were targeting our interventions. But again, this is our post-hospitalization program, and this is primary care clinic specialty access type stuff. So we've been doing a lot of follow-up work in CBC tests and pneumonia. We did a nice study on VIP services at university hospitals, but I wanted to just call out some really amazing work that people in this room have helped with during the COVID-19 pandemic. Again, we've grown from 13 to 50 hospitals in that time period. And in the pandemic, we set up all these work groups to start sharing best practices around what we were doing for discharge practices. We did a couple of neat collaboratives on early in the pandemic, we didn't know what to do with DV2 prophylaxis in people with bad COVID disease, what to do with anticoagulation. And we set up these work groups that ran off Zoom. We had Google Docs, all those kind of neat virtual tools, and did a lot of great work together. And this is just a sample of all the papers we did when we're all kind of seeing tons of patients on the wards at the same time. So I feel like I can't mention home without at least calling out people that did all the amazing work with us during the pandemic and now afterwards. All right, so that's the end of Act 1. You with me? All right, Act 2. So here's probably what you're here to hear about. So diagnostic errors. So about the beginning of the pandemic, we got funded to do this study called the UPSIDE study, which is an ARC-funded research study. And before I go into UPSIDE, I want to take you in the Wayback Machine just for a minute. I think one of the most important papers, maybe of the last half century in medicine, is this paper. This is the study that studied, it was the first to look at safety and errors in healthcare. It was a study from Lucian Leap and Troy Brennan out of the Harvard group. And they looked at a bunch of charts of people in Colorado, I think it was, and to figure out where the errors were. So everyone talks about the Iom Report, the errors human. This is where that started from. If you look at, so they looked at all these patients, they screened through all these charts for all these index events. You can kind of think of this as being, this is going to come back to this is essentially what we were doing now. But these are the index events they used, and they looked at the charts to see if an error took place. And this is the summary of the top events or errors they found in 1991. Actually, it's probably like 89 to 90 when they did this study. So the top half is operative stuff, no surgeons in the room, so we won't talk about that in too much detail. But diagnostic mishaps, second most common error type in that study in 1989-90. You'll notice that's also if you look at due to negligence, that and therapeutic mishaps are the top most common in terms of negligence. But drug-related errors were the most common. So I think at that point, the world kind of began to pivot more towards the drug-related errors. and started, but also viewed therapeutic and diagnostic errors as systems problems, because that was the thinking about safety. Remember the Don Berwick quote, every system is perfectly designed to achieve the results it does. So I think that's the way they turned the diagnostic error findings into the next 30 years almost of safety innovation, safety improvement in healthcare. So we got funding, as I said, from ARC 3 years ago now to do a reasonably similar study, but looking at patients who died in the hospital or went to the ICU after 2 days, and to look at the risk factors. What was the underlying pathophysiology of errors? And then aim 3, I won't talk about today. We're trying to build some machine learning models because it's the 21st century. You can't not build machine learning models, but because we think there may be an opportunity to build better risk prediction for diagnostic errors. We won't talk about that today. It'll be maybe a later webinar. We partnered with Vizient. Do you all know who Vizient is? So it's a big healthcare purchasing organization, millions of hospitals, millions of patients. So we got 31 hospitals, 3 of whom were safety nets. We used the Vizient data to flag for the deaths and ICU transfers. And if you think back to the readmission study, we did more or less the same thing. We got the cases together. We had a standard adjudication tool. We had 2 doctors review every chart together. It took about a half hour, 40 minutes each. And if there was a tie, like I couldn't decide with my colleague whether it was, we'd throw it to a third person. And we did a lot of work about how to get the quality control within sites and across sites together, which I won't go into here, but it's just suffice to say that's why it's taken us 3 years to do the study. There are 3 key parts of what we collected when we looked at the charts. There's this tool called the Safer DX tool, which is a validated tool to help you kind of use an algorithm to go through a chart and see, at least give you the index of suspicion that error took place. We defined a level of harm going back to this thing called the NCC MERP, the NCC MERP scale, which you'll see often in drug errors, which is, it says like no harm reached the patient, error took place, but harm, there's a bunch of scales, which I'll get to in a minute. And then the DEAR taxonomy, which you may not have heard about, which is a tool that came out of the safety group at Harvard that gives you underlying causes, kind of the pathophysiology of why an error took place. And this is a little bit complicated, but it's worth going through. So if you think about your head as a doctor, this is what we're trying to get into with the Safer DX and the DEAR taxonomy. We can pretty easily measure age and comorbidities. We can figure out who the attending was. We can look at like the teaching, non-teaching service or how busy it was at the time. What we do with our chart review is we use the Safer DX to actually call a diagnostic error, look at the chart. And that with the DEAR taxonomy, we're trying to just really dig through the processes we can see in the chart or elsewhere to figure out if they were anchoring on something, for example. Makes sense? All right. So the DEAR taxonomy is 9 big buckets, just so you understand where it comes from, because it'll be relevant in a minute. And each of them has a bunch of underlying process faults. So underneath access and presentation faults, there's these questions here, like there was a failure or delay in seeking care, denial of access, delay of care in ED, transfer to outside hospital, those sorts of things. And there's some more down here from our follow-up and monitoring. And if you're putting our thinking cap on like how are we gonna get this from medical record, we're gonna go through an exercise together. All right, so here's a case, real case for one of our 2,400 we've done. A 72-year-old woman with non-ischemic HFrEF came in for a diagnostic hysteroscopy. Had an uneventful removable polypoid mass, but complicated by a small uterine perforation, diagnosed by an irrigation fluid deficit. They put in more fluid than came out afterwards. As an internist, that's how I put it together. Hope you understand. So she got admitted to medicine afterwards with hypoxemic respiratory failure. And I do enough post-op care, like, well, I think the documentation was a little bit like, what did you aspirate? There was some pulmonary edema because there was more fluid that went in than it came out. Like, let's just kind of watch her overnight. And then the next, like within the day, she became hypotense, had more hypoxic respiratory failure, AKI, became encephalopathic, got a rapid response call. This is like that horror movie. You can see like the person coming out of with a chainsaw. So this is what's happening. So you see it happening there. Rapid response comes, pressure started, antiboxed, goes to the ICU, gets intubated. At that point, this is 36 hours after the Surgeon General surgery is called, and finds out that she had a perforated small bowel, did the XLAP, but patient ends up expiring after hemodynamic collapse and the patient's family decided to withdraw. All right. So we had to look at this. Who thinks diagnostic error happened? I didn't give you the whole chart. This is a very complicated case, but maybe have a sense of whether they think a diagnostic error happened here. Again, and for the purposes of this study, and as the IOM at NASM defines, a diagnostic error isn't just something found at autopsy. It's a delayed diagnosis. Like you didn't start treatment for X appropriately. You didn't send the right test early enough. So was there a missed or delayed diagnosis here in this patient? Show of hands. Seems like everyone says so. All right. So this is what we said when we looked at the case. So the clinical exam, which she had pulmonary edema and kind of a more tense abdomen, should have prompted early evaluation because it really wasn't consistent what you'd expect after a uncomplicated, as apparently these hysteroscopies, if there's a perforation, doesn't usually look like this. The testing, AKI particularly, should have prompted earlier reconsideration. The physical exam, I didn't get into much detail, but certainly the delirium and some of the aspects of her abdominal exam should have suggested an alternate diagnosis earlier. And then we agreed very strongly that an error took place. That would have been an almost certain diagnostic error here. Every one of our cases has a little summary from the reviewers. So there's a consideration of bowel perforation by the primary team. We've all been in this situation with multi-consultants. So we're worried about a perforation, but the gynecologists who do this a lot don't think so. So they trusted them. So they focused on that, and the gynecologist was much more focused on, like, they think she aspirated, like, so it seemed like that kind of interface between the consulting service and the primary service, as well as kind of maybe anchoring on things that they thought were common or recognizable to them, may have led to the diagnostic misadventure here. So again, the DEER taxonomy, again, think of it as exploding the list of things that led to this event. So inaccurate or misinterpreted exam. Failure to order a needed test. I think the CT scan could have been ordered earlier. Recognize early urgent condition. This wasn't so much in the transfer to the ICU, it was more just recognizing that something really different was going on. So the urgent condition recognition was important there. A referral to surgery, you can see the consultation performance, and then overweighing a lower likelihood diagnosis. All right. So like I said, we work with Vizient. We looked at all adults admitted to our 31 hospitals with a medical diagnosis that's defined by Medicare, which gives about slightly more than 500,000 admissions in the calendar year of 2019. 27,000 initially met our inclusion criteria. We used a random digit generator to select about 5,000 of those, after which we excluded 1,800 because they got transferred to the ICU for a protocol, or they were never cared for in a medicine service. They were miscoded. We have a number of sites in our network who do trauma care, or some, so especially like bone marrow transplant. We thought it wasn't fair to hold general internists to those cases. We excluded those, which gave us 3,000 in our review pool. And we worked from top to bottom in each site until each site got 100 cases, which gave us 2,491 cases. Actually, a little bit more now because we're just finishing the reviews. But so we're going to talk about the 2,500 cases we've seen so far. So of these 2,500 cases, about 23% had a diagnostic error, the missed or delayed diagnosis. We didn't try to dice those two things apart because at some point, even the misdiagnoses were delayed, and a delayed diagnosis is a miss. It kind of becomes very difficult to tell when one becomes that. We decided that the global definition was worthwhile here. If you look at the harm ratings, they produced permanent or temporary harm in 13% of patients. Starting to feel like that study from 1991, right? Among the 1,800 or 1,900 or so patients who died, the error led to death in 7%. So if all deaths in the hospital, better way to say this, a diagnostic error produced the death in 7%. And if you had a diagnostic error and you died, it was 30% likely the diagnostic error led to your death. Does that make sense? You're getting higher and higher kind of influence on the outcome. If you look at the prevalence of the underlying, this is the Deer taxonomy of big buckets, not the small questions. You can start to get a sense for some of the prevalence. Errors in assessment, very common. Access presentation faults, and a few in the middle with errors in testing kind of in the middle. This is the kind of the overall prevalence. Again, these are the top three. If you look at the adjusted odds, you see a slight reshuffling here. Errors in testing stays there. Teamwork was very uncommon, but got a signal just the adjustment like a little bit by chance. We'll come back to that in a minute. And then assessment still stays really highly associated with diagnostic errors. And again, I'll take you back to that attributable fraction idea I showed you in the readmission studies. So again, this is the proportion of diagnostic errors that could be prevented if you took away access presentation faults. For example, this is not significant, but bad example. So the most high value target would be assessment, errors in assessment. The next would be errors in testing. Again, think about the CT scan in that case I showed you. Is there a way you could have gotten that ordered earlier? And then follow-up and monitoring. And there's a bunch of other ones that are kind of clustered below that, but these are the top three: follow-up monitoring, testing, and assessment. At least from our study so far. So you can think of a few limitations to this method. Probably have a few on your top of your mind. So I think the biggest one is this retrospective study. It's a lot of hindsight bias. We got around that by trying to be as honest as we could with each other. Like, don't try to read someone's mind based on what's on the medical record. But we also said, you're reviewing your peers' charts. Be honest and fair to them as well. If they didn't write it down, we can't prove that they were thinking about it. So we had to constantly fight those have those discussions. We did not have any really good measures of communication between providers. As I think I was most, but our next study we'll have to dig into that more. But were they actually talking about these things by phone? Was the page pattern look like? That kind of stuff. We can't measure that directly. So certainly a limitation. And we can only measure, like I said, we only measure what's in the chart. But in a world where we're communicating largely through the chart these days with handoffs, this is actually probably not unreasonable. But certainly a key part of what we're going to be digging into as we do more sub-analyses and more future studies. All right. I keep hitting that, sorry. So what's next? I'm finishing this a little bit quickly. So what's next? So go back to our New England Journal paper. Again, remember that diagnostic mishaps were number 2, right? Well, I'm going to go back to the drug error, ADE error literature, just to kind of give you a sense of what that field did. So soon after, not soon after, it was 98, but there was a lot of studies kind of like Upside that went through and dug through the causes for drug errors, resulting in this pretty important study that showed all the underlying causes and what were most important. And because we're internists, we did systematic reviews to systematic reviews. But you start to get a sense the literature was starting to crystallize around some key underlying causes of drug errors. So things like wrong dose, drug interactions, allergies, wrong patient got the drug, wrong drug got to the patient, and then just the known adverse effects in a vulnerable patient, like not the right choice. So everyone's mind, we're close to Epic, so I'm kind of contractually obligated to mention this, but everyone's mind goes, oh, the EHR is going to fix this. But remember, that's not what we all what we did, right? EHR is great. It gives you standard buttons to pick things. You don't kind of script. We were joking about how my handwriting was illegible as a resident. So like I was constantly getting phone calls like, is that a 7 or a 2 on your orders? Like we don't get those calls anymore. So EHR has definitely fixed that, transcription errors. But we've done a lot of other things. So we changed the human technology interface. I think if you had to pick the biggest technological advance in drug errors is that the barcode med administration that gets the right drug to the right patient, matches it. Same for transfusions, but again, this is not an entirely EHR-based intervention. We have reference standard databases now, like data lives behind Epic, data lives behind all these drug testing, the allergy, all those data are in there, and kind of you're constantly being guided towards the choice of the drug that's least likely to cause a problem based on creatinine or whatever. And this has only become more complicated as genetic testing becomes more common. And I would just say that probably code number one with barcode administration, if you had to pick another intervention in your hospital, it would be put a pharmacist on every team. So that has been the other key learning from the patient safety med error world of the last 20 years. The pharmacist here, I think, is the cool one in the leather coat. If you load the ICU literature, like that's the key to keeping ICU patient med errors down. So again, this is not an entirely computer-based intervention. And then because I do a lot of this at the university, and it's stitched together with policies, procedures, and standards. You know, we have a med rec policy, we have a policy for med administration. We don't have the same policy for diagnostic thinking or diagnostic timeouts yet. So again, I would say we're very much like the ADE world of 2000 or 98. We're starting to get our arms around like what causes diagnostic error. We haven't quite dug into the interventions yet. There's a little bit of interest in policies and procedures. You all work on diagnostic timeouts here or therapy, that kind of thing. It's kind of a thing in the med ed world, and some residencies are doing it as part of their CPCs. Some people are thinking about performance feedback, having you look at your cases from the last time you're on service to see how people did. So there's some projects on that going on, but they're not really built what the safety world has learned so far. There's not much of a computer aspect to it. They're not baked into existing quality and safety programs per se. So I don't know what this looks like yet for diagnostic errors. I think we're going to get there pretty quickly. The safety improvement model here, this is a little dizzying, so I'll try to walk you through this. So just think about this as if instead of diagnostic errors, this was a bed fall or a DVT in your hospital or sepsis. You've got some system over here that produces the bed fall, guardrails, that kind of thing. And you've got a way to ascertain whether the error took place. The big difference in diagnostic errors, you have to get in someone's head. But we have systems in place that do system reviews, event reviews. We have committees. You can think of one like root cause analyses or safety review committees that do this work already, that look at the work system, figure out where the outcome took place, and then display the data somewhere on a dashboard. Right now, you could probably see what your CLABSI or CLAD-CAUTI rates are, and they could probably tell you which one of these are preventable, which ones weren't. They can say which ones had the appropriate sterile barriers placed, which ones didn't. Give you like that all exists. And for this next round of funding, which you just heard about on Monday, this is what we're going to try and do with the next version of Upside. We're going to use the methodology you just saw, bake it into safety and quality review infrastructure at hospitals, and see if we can start on the same journey. And then the cool thing we're going to do, because we're interested, we like to teach, if there's this idea in the safety literature where safety 1 is like you tell people when they've done something wrong, you work on the faults. Safety 2 is you say you did something really right. And there's nothing more disheartening than getting all of your bad news about your patients that did poorly. What we're trying to do is also give people a sense of what they did really well. Like, that was a great catch. Like that patient with the ICU, but you did everything you possibly could, and we think you did a great job. So one thing we're going to work on is this kind of save here, which is people were predicted to have a higher risk of an error, but didn't. So as an adult learning theory model, this is going to be part of what we do as well. All right. So Home Run is definitely a practice-based research network. I think we love our clinical trials colleagues. We love the investigator-initiated research. But we've really felt very strongly, because hospitals are so embedded in what we do in healthcare and hospitals, that we had to kind of let those questions guide us, and diagnostic errors is an example of that. we're really about dicing out the pathophysiology of underlying problems. We don't want to say do everything at once. We'd like to say which ones are most important. So again, a theme of what we've shown you so far. And we've become a platform for developing additional researchers in hospital medicine, and have been doing that since day one and are getting a lot more momentum, which is I'm particularly proud of. But the clinical takeaway here is I just want you to know that diagnostic errors we were surprised how many there were. 23% is extraordinarily high. I didn't get to this in too much detail. It's about what the autopsy literature was 20 years ago. It's a little higher than some of the studies that didn't use the kind of review process that we didn't, but lower than ones that use a kind of more ad hoc process. So we feel pretty comfortable. So it's a pretty startling number. And then its contribution to deaths is really a call to action. And again, a reason why I'm so excited for the next round of our funding. And like I said, Upside's really aiming to frame those interventions and move to the next round. And when I did this talk a month or so ago, it was much longer, but I'm happy to give you guys a little time to answer lots and lots of questions. So thank you. Go ahead. Great question. So first of all, thank you for using our study. It's actually Kelly at BI did it. So thank you to you for using Kelly's work. So the question was, is there anything you can do to systematize who should be seen in 7 days? Because not all those 7-day patients are as sick. Not all 7 days are the same as all. There's something equal. Anyway, so I can't say we've solved that UCSF. We have this will probably be familiar to you. There's an automated post-discharge phone call system that gets people to a pharmacist and a nurse, which can accelerate the follow-up. And then it's a little bit ad hoc, quite frankly, at our hospital based on what the primary care doctors want. We have the same policy, 7 to 14 days, latest 14 is optimal 7 days into clinic. And then what happens with the front desk schedulers in our clinic get to work with the primary. We have for a while had a post-discharge follow-up open slot every week that I'm not sure has been sustained during the pandemic. Yeah, so what I would say, I don't think we've solved it. And this is, I'm also acknowledging that this is a gap in my knowledge as a hospitalist and not a primary care doctor. But we've worked pretty closely with them. One of the slides I didn't show because I was worried it'd be overtime, I should have showed it to you, was when we asked the primary care doctors and the hospitalists why people got readmitted, they saw completely different things. It was really interesting. If you looked at the rank list, they were the same, like didn't know how to keep appointments, didn't know how to call, had problems with self-management. And the group, if we asked about individual patients, the hospitalists and the primary care doctor saw things very differently, which has I think made it really hard for us to agree on what the sickest patients look like, if that makes sense. So very different points in their care and have different understanding of their long-term situations. But thank you, great question. question is documentation of things like differential diagnosis or communication with other providers. So I'll start with the second one first. That's really hard. How you document pages and communication, because it seems as someone who has to bill, like you have to document, talk with Dr. blah, blah, blah about the XYZ. So like I do that, but it doesn't represent my thinking. It's just a billing thing. But we've tried to look at, and you may have done this sort of thing too, like there you can look at paging logs, but that, again, that doesn't capture the discussion in the hallway, which I think the most valuable teaching for me is always when you grab the consultant outside the room by accident almost. So how you capture those, I don't know. Again, we'd like to think about for the next study having kind of shadow shoppers or mystery shoppers follow people around, see how they work. The separate part of this is how you do documentation and communication education, I think is where it was. The word about documentation, EHR has made documentation bad, so that's an easy layup kind of comment to make. But I also say that this is an opportunity I'm working on my residents to say, copy your notes forward, please feel free to do that. But your job is not to regurgitate everything that's happened on the record every day, but I want you to do two things every day. Change the one-liner, because the one-liner ends up being this concatenation of everything that happened. Make sure that represents the patient as today is, and then just change the problem list, for God's sake. Just reorder it in the way you think you're thinking. I don't care if you have all the CT scans and everything, but just reorder them in the way you think the patient's thinking. So that's Auerbach. I don't know if the rest of the world, but I think that's what the EHR we can start to move towards. Like you start to reprioritize problem listing, because it's hard to, having just been a few days on non-direct care service, like when you got 10 patients and they'll have 20 problems, you could spend all day doing nothing but notes. But that's the one part I think is important. And you can audit that. You can actually look in Epic and see what's changed from day to day and see if they've actually changed their problem list. I think that's where signal is going to be, if they actually looked at the problem list. And there's other things you can do looking at ordering. How to bake that in an education program. I think this is totally suited for adult learning theory. But it means a little different than kind of CPC discussions. It's probably more along a coaching or academic detailing model, where you get to meet with a trusted colleague or a trusted program director and your cases and just kind of go through that on a regular basis. It's kind of an extended version of the diagnostic timeout idea. And I think that's where, I think the safety world can very much learn from adult education and learning theory training. I did a stint on ABIM for MOC. This is what we're trying to do at MOC for a while, like look at your cases, kind of reflect on them, like reflection is part of it. So again, I'm blathering a little bit because I'm really passionate about this area, but I think that's, if you had to pick a big difference between the safety world and as existed in the diagnostic area world, it's that. It's like, how do you work with your colleagues to become a better doctor? Because no one got into this business to make bad decisions for their patients, right? Go ahead. Go ahead. Thank you. So thank you for calling me out on that. We don't know yet. That's probably where I got the funding. We have our ideas about how to do that. We go back. I don't know if I can go back to the slide. I'll skip it. Remember, there's like there's a low risk for error at the top, kind of no errors, and then with the red risk for errors at the lower side. We think at least there's one in the SaferDX tool, you can get a score for how likely an error is to have taken place. And we think one way to do the good catches is to look at the people who SaferDX says, we think there's an error here, and our group says, no, there wasn't. So that'd be one way to catch safety too. And then we're getting a few expert clinicians on our committee to look at some cases with us and say, where would you call good catches? It could be, and it's possible that the catches may include you made an error, but you caught yourself and you saved the patient from harm. Again, that's why we're going to spend the next 4 years working with you all to figure this out. But it's a really important one, because it's a little bit like coaching. I coached Little League for a while, and if all you tell the kids is you struck out, that was awful, why'd you do that? Don't do that again. Like, they're never gonna hit the baseball ever. So you got, hey, it was great. You stayed in the box. You swung really hard. Like that's what we're thinking about here. You got to coach people to a better level of performance. They have to hear both the good and the bad. Sorry, thank you. Great question. That is a really great question. So the question is, yeah, so how do you balance the costs of making diagnoses with and is there an acceptable diagnostic error rate? So I'll answer the second question first, which probably there isn't an acceptable error. It's kind of like that mission statement, like we're going to prevent we're going to eliminate all preventable errors. So that's probably the moral framework we have to work from. There's an interesting paper maybe 6 months ago in JAMA, I forget who wrote it, I think it might have been Catherine Lucy, about diagnostic efficiency. So you can certainly avoid testing problems if you order all the tests at once. Get the ProCal, the blood cultures, do all the tests, the BNP, get an echo, like you'll not, so that's not the way, we don't want that to happen either. So that's certainly a balance. I will tell you that people who have diagnostic errors in our data have about a $5,000 to $7,000 extra cost, even after adjustment. So not to say that justifies spending $5,000 on tests beforehand, but I think there's a downstream cost of making errors as well. But I think this is, again, another neat place where the caring wisely efficiency value world meets up with the safety and education world in a really neat way. Great question. Thank you. Go ahead. Question. So how do you spread diagnostic excellence outside communities where there's a lot of learners and experts around? So I can't say we're going to solve it, but I think we've been able to improve DVT prophylaxis and line infection rates by building systems that look for those things and try to find underlying causes. So I don't know if we're going to get there, but that's kind of what we're hoping with this new project called ADEPT, which is bake this into your systems to help at least figure out when errors took place. But it's still very doctor focused, right? We don't have a great way yet to do a team-based diagnostic approach, which is really important as well. Also, as you were saying your question, I was also reflecting on the idea that like we in hospital medicine, we're onboarding junior people every year. So there's a big need to develop those people and mentor them. They often came right out of residency and they've gone from seeing 6 patients on their own to 12 or 14. They've not been on, so there's a lot of like faculty development work. But then there's people like me, I was joking about this last night, who are out of practice, out of residency for a couple decades now. And like, when did HLH happen? That like 6 months ago, like everyone's got HLH now. Like, when the heck did that happen? So like, how do you keep people up to date and kind of not missing that diagnosis, right? So there's both the onboarding and then I mentioned I was on maintenance of certification. What we were really worried about with the boards examination, you take your boards once every 10 years, like there's no guarantee you're still a good doctor. So kind of, again, what we're trying to think about here is like, how do you both kind of launch people and maintain their excellence over time? And It's, again, a mix of system stuff and probably some excellent coaching.
Dr. Auerbach, that was just fantastic. I'm really kind of curious about if you could expand upon the cases you went through on consultant bias, and how do you get the feedback to the consultant? So being interested on quality and speaking of knowledge, oftentimes it's not only bias, it's sometimes also denial. You're not going to see that but some of the complex cases presented, how do you get the feedback?
It's a great question. So I use that, hopefully no, so how do you get the feedback to the consultant? Like in the case I showed, there were certainly errors on both sides, but the fact that the gynecologist didn't feel like that was a complication they could either agree to or recognize or want to think about was part of the picture. And not because they're bad people, but because that's just hard to think through. My wife's a surgeon, so I live this not infrequently at home. So again, the model we're thinking about for ADEPT, the next study is treat it like an RCA, where there's a summary at the end of these that gets the right information to all the stakeholders involved. We are, the first version of this is probably going to focus on the provider teams. But I think, you remember that errors in assessment was the most important part of this. We may end up, I say this with a kind of depressed feeling, we may end up back at better sepsis prediction rules at the end of all this, who knows? And why don't we have better sepsis programs or better decompensation or instability programs? Like that may be part of what we learn too. Like, and as you know, that's like a nursing thing, that's rapid response, that's respiratory therapy, that's the doctor. So again, we're trying to design something that is flexible and doesn't forget that we have programs that do this already, like the RCA program. Thank you. Great question. Yeah.
Thank you so much for this.
Are there any signals from the data we're seeing so far that suggest like mistriage to the wrong service as part of it? So we have those data. We haven't dug into them yet. This case did have that flavor for sure. I think this is a patient who's going to have a come and go surgery, was supposed to go home, and so had a potentially medical complications. So they came to medicine off of that. But clearly part of the picture here. We have a suspicion that that's going to be a reasonable part of this. There's also a reasonable number of transferred from outside hospital patients in our cohort that we don't think the reason for transfer is the diagnostic problem, but often the gaps in communication are pretty challenging. So that is a sub-study that Stephanie Mueller, who some of you may know, is digging into now. Care Everywhere has solved a lot of this, but there's still stuff that you just don't quite know, like the context for the 3 CT scans on one day, like why did that happen? So that's the stuff that we think is missed quite frequently with transfers.
Had a few questions on Zoom, so we can go through some of those. So let's see, the first one we have is, can you share some of your information about machine learning methods or how you aim to apply data science to reduce diagnostic errors?
Great question. So I'll have to restate the question because you've done so nicely for me. So aim 3, as I mentioned, is using machine learning methods. We have 2,400 validated cases. We have 26,000 cases that also had the event, but we haven't looked at yet. Vizient data are not as detailed as other EHR data. They have charges for things like Zosyn. They can't tell you the dose. They can tell you exactly, they can tell you how many times it's charged for under data. They can't tell you the hours, for example. For some of the hospitals, they can tell you that a lactate was ordered, but they can't tell the result. So we're trying to do all that data cleaning. Our hypothesis there is that just the patterns of testing for lactate, I have a hypothesis about galactomannan. Like all these random tests we sent, we're kind of doing gropograms, we call it UCSF, like we just send all the tests. So we're looking for those sorts of patterns. And so far we have, interestingly, we found nothing yet. Like there's no discernible pattern that we've seen. We're gonna go one more layer into the Vizient data to see if we can find anything in comorbidities or ordering patterns. But it may be at the end that these aren't the right data, and we had that suspicion when we started. We thought it'd be worth trying because, as you know, Vizient data are ubiquitous. And if we could bake this into a Vizient data dashboard for your CMO or CEO, that would have been a huge win. We're not sure we're going to get there. So then we, alluding to this multiple times today, but our next day, we're going to pull Epic data from sites and look at charges. We're going to look at results. We're going to look at ordering patterns. Like, did you order something and cancel it and then reorder it? And then there's an audit log as well. It looks at activities in the medical record, like who accessed the record when and who looked at which parts of the medical record, so that we can say, one of the things we looked at was failure to collect a good history. So like looking at things like the number of times you accessed CareBeware, the number of times you looked at the primary care notes, like that kind of information density would be part of the next model. So we have not been as successful in the machine learning yet, but I think that's where we're going. And the reason why upside is so important to me is that most of the machine learning work in this space I've seen to this point has been doing off events that look like a diagnostic error, like transfer to the ICU could be a diagnostic error. We actually have diagnostic errors, so we can build models that are actually calibrated specifically to the outcome we're interested in.
All right, and the next one we have is, can you estimate a relationship between diagnostic errors and the clinical handoff of patients between services or teams?
Great, so related question to Anne's before. We haven't looked at that yet. The data are there. Again, we suspect it happens frequently. I was talking about this last night over dinner. We have a number of patients who are transferred out of the ICU in the evening, early evening, covered by night float for the evening. And the next morning I pick them up on the teaching or non-teaching service. So I'm like 4 doctors removed from the original doctor at that point. We think that's a pretty high risk scenario. And we're digging into those specifically. The number of handoffs, particularly in a situation with lots of night float, is a big question of ours.
All right, and then next question. What are your future plans to get past the limitations of chart review to understand and incorporate other systems issues into diagnostic error? For example, time pressure, workload, technology design, and display of information.
Great question. So I had that figure with the big box in the middle. That's the deer taxonomy list. There are a bunch of little boxes outside of it that we do have those data, like the number of cases on the service, number of admissions and discharges, workload. We don't have burnout data yet, which we wish we had thought of to collect before we had done the study, but certainly key. Those are the kind of, I'll keep hammering this point. Those are things that the systems and safety world have thought about like for 2 decades now that we want to bake in, because there's obviously some overlap between the two. And those are, I think those as potentially modifiable risk factors that we can help you give more time to think through a case more carefully.
Right, and the next one, is there currently research into decreasing diagnostic errors in a clinic setting? And what currently is the best way for a clinician to reduce that error risk?
Great, so, and by clinic, I assume you mean outpatient clinic. Ironically, despite the preponderance of focus in the inpatient setting for medication errors and things like infections, most of the diagnostic error world is actually outpatient. So some nice work. The key work is Hardeep Singh's from University of Texas as a group in Baltimore as well, who looked at things like delayed diagnosis of cancer in ambulatory patients, or things that aren't followed up off a chest CT or incidental findings on a chest CT. And then the ED as well for people who come in with chest pain, which is a classic ED conundrum. And then all roads lead to epidural abscess, we joke, like the back pain patient who comes in a couple days later with the epidural abscess. Like there's a lot of neat literature in the ED world that talks about those prevalence rates. I will say they're much the same as the inpatient world. There aren't yet any great systems in place for it. There's a lot of post-clinic follow-up things. There's a lot of systems in place now to make sure that patients with those incidental findings they get a repeat imaging, which is a key systems change. But whether or how a subsequent diagnosis is fed back to the original doctor, I've not seen those studies yet. The other title for this talk is the end of the beginning in diagnostic error work. I think we are at the end of the beginning of where we're understanding of the disease is the disease itself of diagnostic errors.
Great, and then we have 2 questions left. So the first one, were patients made aware of your findings? And if yes, what were the legal and financial ramifications?
Great question. So we started doing chart reviews in 2020, mid 2020. So most of our patients were dead, and all these charts were anonymous anyway, so we couldn't get back to the patients themselves, but we did give the results of our case reviews back to the quality officers at each site or the division. So just wasn't possible for kind of practical reasons to give patients and families the feedback. We do have a PFAC at Home Run, which we've been sharing these data with, and they were pivotal in helping us get the next round of funding. And they're thinking about, in ADEPT, we're going to be doing this in a kind of, not a real time, this will be within 7 to 10 days. So it may be possible to give patients feedback. How we're going to do that is going to be very site dependent because every site has its own disclosure rules. So we may not do it as a requirement of being in the next study, but some hospitals, Michigan, ours, Brigham, they have a clear requirement to disclose errors to families. I see nodding here, suspect you have the same thing, but like we just have to work with local programs to make sure that they know how that what we found, and they have to review it themselves and then they put it into their own systems. Great question.
All right, and then last question. How do you assess and study active surveillance post-discharge as a needed component of inpatient care?
Active surveillance after discharge. So this is where I can say, like I play one on TV. I don't do this super often, except that we did some work a couple years ago looking at the influence of post-discharge phone calls on readmission rates and patient satisfaction. So patients are satisfied, but you end up getting more readmissions because you find stuff to bring back people back to the hospital. So it's a little bit of a know what you're in for. But I think it's important. The hospital medicine world now is starting to really think carefully about whether it should also be part of the hospital at home world, which is remote monitoring, kind of virtual home visits, working with nurses, home nurses and home healthcare aides in a more intensive way. They do labs once a day. You can do remote. There's a lot of things that are emerging in that space that hospitals are thinking about quite a bit. And I think it's a hot area. There's a strategic question from many divisions about whether they want to do that, or whether it's better to be done by geriatrics or primary care or jointly or pop health. But I think it's a really key area. I think you remember that 7 to 30-day curve, the after about day 8, I think those are the people who you're thinking, like, that's your complex care management, your population health care management group. They are focusing there. And before that, it's probably your transitions of care group. But great question.
All right, great. Well, I think that's all the questions. So thanks again for a great talk, and thanks everyone for coming.